Hi, friends. It's Sam Collins again, your coding and billing expert for the H.J. Ross Company and Kairos Secure with another episode to try to make sure your practice is always expanding, thriving, and compliant. Today's episode, I'd like to discuss a little bit about documentation. I get a lot of calls and inquiries about what should I document? How do I document? In fact, I deal a lot with audits, unfortunately. And when an audit happens, the main thing they're looking at is what you billed for reflected in the records. And I want to focus today on chiropractic manipulation because I want to make sure there's a good, clear understanding of what are the minimum standards or the best practice standards for you to document manipulation properly. Because I've had some offices that have had issues recently on the proper documentation. So let's go to the slides. Let's take a look here at what's going on with documentation in relation to manipulation. It's one that we think might be easy, but there's a couple of points and tips I want to give you here to focus in on. So as always, here's the company website for me as well as my email. So you're welcome to reach out. However, let's talk documentation in general. And one of the things I deal with often, again, as I mentioned, is you billed for three things. Did you document three things? So I want records to reflect that they maintain their accurate records for documentation of the services they provide. Make sure if you're billing a three-region manipulation, three regions are documented and diagnosed, or a therapy and so forth. You should ensure that the claims to submit are supported by the documentation. This is where we run into problems. A checkoff list that says you did manipulation or any therapy would not be adequate. That is not enough. Good documentation practice, of course, ensure you receive appropriate care for the patient, but also you rely on our records to see how the patient has done, how they've responded. Really, it's a legal record more than just our chart note. So it must reflect and identify the services. So E&M services must match the billed service, of course. Well, if I'm billing a 203, did I do enough time or did the medical decision making hit? Or how about therapies? If I did a therapy, what therapy? Where did I do it? How much time did I spend if it's time? And for today's purposes, I want to reflect and focus on CMT. And I want to make sure that you're focused in on two things about it. It's reflecting not only the regions manipulated, but the diagnosis as well. So we got to be careful. Technique is not the driver. So I want to kind of focus in on a little bit on what the gold standard is of documentation. And I would say for me, this is my own opinion, the best documentation is one that another provider, another chiropractor could read it and perform it. Like if I just checked a box that said I did ultrasound, would that be adequate? No, it wouldn't because, well, where did I do it? What intensity? And all those things have to be there. Same with manipulation. You can't just say I did manipulation. You have to identify, well, where did we do it? And then, of course, it matches. So make sure that someone could read it. In fact, if you've ever seen a surgical note, I grant you, when you read it, you'd be surprised how much of a cookbook it is of how things are done. And I'm not saying we have to be overly detailed, but have reasonable details about the services we provided. So since we're talking CMT codes, let's take a look directly at the CPT manual. And let's focus in because, of course, we are given three codes for spine, one for extremities or extra spinal, that deal with the number of areas we manipulate. So let's make sure there's a good understanding of what these are, because this is one that's, I will say, controversial by some, but it isn't. It's been set in stone for quite a while. We have 5 spinal regions. Cervical. Now remember, cervical includes the atlanto-occipital joint. It is not separate. So even though you can see a diagnosis code M9900, that includes the occiput, that doesn't mean it's separate from spine for that purpose. It also includes thoracic region as region number 2, which is obvious, T-spine. However, remember, it includes the ribs, costovertebral, costotransverse. So ribs are not separate. The lumbar region is unto itself. And then we have the sacrum. But then the final region is the pelvis. And people think, well, pelvis, what do we mean? For the purposes of CMT, we mean the SI joint. So specifically sacroiliac. So you can see there's a lot of crossover with sacrum and sacroiliac, but those are the 5 regions that we have to determine which code we're using. You're all familiar with these codes, of course. They're based on regions. However, I want to focus on here. The code is determined by diagnosis and regions manipulated, not your technique. And this is one of the areas we've run into problems with for our profession. You might have a provider that does diversified, Gonstead. Maybe they're doing Merrick or any other type, including activator. And with those techniques, it is not often that you might adjust multiple spine areas. I know providers, when they have a patient with a cervical problem, but they're doing diversified or Gonstead, they may adjust the knees and the hips and all those areas. However, the code they use is going to be cervical because the diagnosis reflects cervical. So first things first with documentation, make sure your diagnosis matches the number of regions so that you can bill appropriately. So if I diagnose cervical and thoracic, but you still in turn adjust the lumbar and the sacrum because you want to align everything, I'm in on that. But you cannot bill a 98941 because you've only diagnosed two regions. So be very conscientious to not overstate based on technique. Now, how do we know how we document and what we document? Oh, by the way, a quick note, extra spinal means anything extra spinal. A quick note on extra spinal. It is billed for one unit, no matter how many areas you manipulate. So if you do the shoulder, the elbow, and the fingers, the knee and the ankle, all in the same day, it's still just one unit. That code is limited, but remember, have to have an extra spinal diagnosis, of course. All right, well, let's talk about the documentation part. Let's look at what CMS says. CMS is a little bit more specific. They want to have a very specific, precise level of subluxation. So when documenting manipulation to Medicare, you must have a very specific level, and it must name the spine, not just cervical, not thoracic, but very specific vertebra. So obviously the occiput could be occipital, cervical C1 to 7, atlas axis. Any of those can be named. Now, if you want to use the numbers, you can. If you want to name them, you can as well. Costovertebral, okay, is going to be part of thoracic because notice thoracic is the dorsal spine, but notice costovertebral, costotransverse are included there. In addition, it includes ribs 1 to 12. So again, ribs are going to be included. The lumbar spine, kind of obvious, the 5 lumbar spine. The sacrum, or excuse me, the pelvis, if you will, is going to be the SI joint. And then the sacrum is the sacrum itself, but that could include the coccyx as well. So what Medicare is going to look for, though, and this is what I want to make clear, when you're documenting for Medicare, it is not enough to say cervical. You must say C1, C2, or occiput. You can also indicate regional. You could say lumbosacral, because if I say lumbosacral, that's indicating that it's L5S1, so a transitional area. But be very, very specific. Where I have providers run into problems for Medicare is they don't name the vertebra. Medicare requires the vertebra because, of course, we have to document subluxation, and the subluxation has to be to a particular vertebra. Just simply name them. So what do they require on a visit? Well, obviously, we're going to do a SOAP. We're going to do our little history, symptom review. We're going to do our physical exam part, the PART. We're going to evaluate how the patient's treated. But then here's the big part that I want to make sure we're getting for today's topic. The treatment given the day of the visit, you must indicate to Medicare the specific level of the spine you manipulated, not regionally, but vertebra. So for Medicare, you must indicate the adjustment today was to C1, C2, T5, and L4. That specifically, and must be done each and every time, not once. I would also caution you, don't put down later, say, refer to the subluxation above. Always put the areas you're manipulating right in there in the plan or the treatment area. Don't refer to another area. Don't make someone hunt for it. Put it right there. Be specific. Now, what about other payers, though? And this is where things get a little tricky. Now, Medicare says, give me the precise level. So if you indicate chiropractic manipulation to L5, that's just fine. But notice under Anthem, and this is going to be Anthem nationwide, they want, obviously, the location. But notice something specifically, and I highlighted or bolded it. They want the regions adjusted. Now, wait a minute. They said regions. So would these plans accept saying cervical? They would. You could say cervical or lumbar. However, notice what they require. And this is taken directly from their manual. This is not my opinion. It says technique used. Ooh, wait a minute now. That's a little different even from Medicare. Now, remember, Medicare, honestly, you should be indicating the technique because certain techniques aren't acceptable. Remember, it has to be manual manipulation, which Activator does fix. It's manually controlled. So I'm going to suggest you can see here, Anthem is requiring technique. It says it. I'm going to suggest let's start putting whatever technique you have used on a particular patient. If nothing else, just so you remember last time, oh, I did Gonstead last time instead of Diversified or whatever the case may be. So I want to make sure the strictest says for Medicare, they want vertebra. The strictest under Anthem says they also want technique. Now, could you say, hey, for Medicare, I'm just going to say the vertebra, but I'm not going to worry about technique? And then vice versa, regions and but technique? Yeah, but I would start to say, if you're going to document, let's do it consistently across the board and not try to remember, oh, this is Medicare or someone else. Now, what about other plans like Cigna? I showed you Anthem. Cigna gives a little bit more vagueness to it. They, of course, in documentation want the data treatment and the specific treatments provided that match the procedure code billed. So that would mean I would take it that obviously you have to have at least regions and that you've manipulated it. However, they don't give any specificity beyond that. So I would go to the latter, a little bit more relaxed type. And then, of course, everything else that goes to treatment time, and other skilled services, of course. So let's talk about what are the best practices. And here's what I want to do. I want you to do something that you can kind of set it and forget it. Let's not get too caught up. Let's do this. The best practice is let's use the strictest definition by a few pairs, whether it's Medicare or Anthem. I suggest whenever you're documenting chiropractic manipulation, indicate the vertebra. Get away from saying cervical, and also include the technique. Thereby would never be a problem. Now realize it's not unusual that you'll probably be doing that same thing over and over. So you would just be repeating it. I don't want to say cut and paste per se, but essentially repeating it. But I want to be very clear that I don't want to have any issue when someone looks at your notes that it was incomplete. And not having any specificity from anyone that's outside of Anthem or the others, let's take it the stricter route. Why make it a big deal? Let's start documenting the vertebra and technique every time. I know several chiropractors that do multiple types of techniques. I know my father myself. I sometimes adjust with Gonstead. I might do a diversified style. I'll sometimes do activator, but I'm going to do what works best for my patient because I don't do only one style. So therefore, I want to know, what did I do with them last time compared to now? So I don't want to just leave it that I manipulated. Be very specific. Now, I guess if you said, Sam, I always do the same technique, I guess so. But remember, doesn't matter. Anthem still wants you to document it. So let's make that the best practices. That way you end any controversy with anyone. If you hold to the stricter level, then it's never worrisome from one that maybe is not as strict, no big deal. But the one that is, we know we are covered. So let's end any guessing. Let's just make it for sure. Not that hard, frankly. However, let's make sure. Remember also, though, if you're diagnosing only two regions, the style of manipulation will not change that to a 4-1. You must have multiple diagnosis. Keep in mind, people always worry, and I've mentioned about audits. I don't want you to get overly worked up about audits, but I want you to be aware of why would someone audit you anyway? Audits aren't as random as people think. Audits happen because they see something unusual. And this is something I deal with our network service. One of the big things I deal with is offices that have issues of this or that we can defend. The good news is we mostly win these. Anyway, your ratio of CMT will lead to or not lead to an audit. These are the standard ratios as determined by Medicare. So this is not mine. Medicare expects the most prominent code you're going to use will be a 98941. That kind of makes sense. People are going to have multiple areas. So a 98941 is going to be more than half, maybe 55 to 60%. Notice 40, 40 to 45%. 42, less than 5%. You're going to have some. Here's what I want you to think of. If you're billing a ratio where 90% of your patients are 4-1, you're highly likely to be audited. Now, that doesn't mean what you're doing is wrong, but it would be unusual. Why are you seeing patients like this way more than the average? You would have to demonstrate that you only deal with more complicated and patients who have more issues. Be careful. Don't fish. And what I mean by this, if a person comes in with a cervical complaint, that's not going to turn into a 4-1. Now, if they come in with a cervical and thoracic and there's a third adjacent area that maybe has some soft tissue findings, maybe. But let's not bump everyone up. Make sure it matches. But the match, because more people have multiple complaints, it would be 4-1 would be higher. And just a quick note, 9943 is not problematic unless you do it all the time. Now, if you're a sports medicine doctor that deal with extremities a lot, maybe your ratio is higher, but that's explained because of the style of practice. Make sure it's not because you went to an extremity seminar on the weekend and on Monday everyone gets adjusted. I have a friend I went to school with that he adjusts extremities on most patients because he finds if you have a low back problem, he always finds things in the knees and hips he wants to adjust. I don't disagree with that, but without a complaint or a specific finding, I would be careful of always adding that in. Be reasonable, be defensible, make sure it's all there and you have a reason for it to be there. One of the things, of course, I'm always going to be here to help. We always have news and updates. Here's our latest blog in our news section from our website, HJ Ross, How to Choose a Managed Care Network. We have lots of videos and other things here that can help you on a day-to-day basis. Look up topics we have there. Also, keep in mind, guess what's going to change October? October 1st, diagnosis codes are updating. Our most recent seminars are covering that. And we also have a service called the Network. If you're looking for help day to day, make me part of your office. It includes seminars as well. But what a great way for you to have some compliance and better coding and billing. I'll guarantee if you join, we'll make you more money. So use the QR code. I hope to see you at a future seminar. Next week's host will be Sherry McAllister. Until then, I'll say, everyone, thank you very much. Catch you next time, my friends.